Welcome to the Fibro-Fix Summit. I'm Dr. David Brady, your host and author of the upcoming book, The Fibro-Fix. And I have a real treat today. Our expert for this segment is really the giant of fatigue and fibromyalgia, Dr. Jacob Teitelbaum. So welcome, Dr. Teitelbaum. Thank you for joining us from Hawaii.
David, always a pleasure to be with you.
Great. And let me just tell everyone a little bit about you. Dr. Teitelbaum is the director of the Practitioners Alliance Network, and he's the author of the free smartphone app Cures A to Z, and of the best-selling book From Fatigue to Fantastic, which I'm sure many of our listeners have read. Also, Pain Free 123, a proven program for eliminating chronic pain now. The Beat Sugar Addiction Now series, the Real Cause, Real Cure, the ebook, 3 Steps to Happiness, and the Fatigue and Fibromyalgia Solution. So he's a prolific author, and he's provided a lot of people solutions to very, very difficult problems. He's the lead author of 4 studies on effective treatment for fibromyalgia and chronic fatigue syndrome, and a study on effective treatment for autism using the NAT technique. He does frequent media appearances. You may have seen him on Good Morning America, CNN, Fox News, The Dr. Oz Show, Oprah, and many, many more. And we're always all jealous of Dr. Teitelbaum for living in Kona, Hawaii, especially this time of year. But somebody has to do it, right, Dr. Teitelbaum?
It's part of the United States, you know.
I'm sure a lot of the people there might disagree with you, but these days. Anyway, I also wanted to mention I had the great privilege in my career of being one of the co-authors with a chapter with you and Dr. Alan Weiss in this great book here, Advancing Medicine with Food and Nutrients, edited by Ingrid Kolstad from Johns Hopkins. So I think that's where we first actually worked a little bit together, and it was a wonderful experience. So I wanted to have you on. The real purpose of this summit is to just bring a lot of information to people who either have been diagnosed with fibromyalgia formally by a physician, or maybe they diagnosed themselves on WebMD, maybe their neighbor told them they had fibromyalgia, and in many cases maybe they do. Maybe they have this sort of at least classic definition or understanding, at least at today, of fibromyalgia being this hypervigilance, sort of hypersensitivity, centrally mediated pain processing disorder. But I think there are a lot of variations actually beyond that definition, and there are so many other things, as you know, medical conditions, groups of medical conditions, or even more subtle metabolic and functional issues that fly under the radar of many clinicians and physicians and get people a diagnosis of fibromyalgia, or they get labeled with fibromyalgia, when in reality these cohorts of people who say they have fibromyalgia have a whole lot of different things going on often. And it takes more than one approach to really comprehensively get them well. And you've really mastered that and have put systems together to help clinicians work with people on that. So why don't we just start off at the beginning and get your opinions on, the sort of the current thinking of fibromyalgia. What is this thing? Is it all one thing? Is it a bunch of different things? Is there sort of a classic, main type that is the real deal, so to speak, and what is the dysfunction, or do you think it's all a bunch of hooey?
David, as you know, this is not a single process, and making the diagnosis of fibromyalgia is not the end point.
Right.
That's just the beginning of getting well. So what's key for people to understand is that fibromyalgia represents an energy crisis in the body, or for any of literally hundreds of reasons, your body is spending more energy than it's able to make. And when that happens, you essentially blow a fuse. It's like triggering a circuit breaker in your home. And the name of that circuit in the brain is called the hypothalamus. That circuit is a small area that uses more energy for its size than any other part of the body. So when you have an energy crisis, it goes offline first. No damage to it. It's like a circuit breaker. It goes off to protect your body in the face of overwhelming stress. That circuit controls sleep, which is why the hallmark of this illness is that you can't get a good night's sleep even though you're exhausted.
Right.
It controls your entire hormone system, thyroid, adrenal, ovaries, testes, pretty much all of it. It controls blood pressure, which is autonomic function, blood pressure, pulse, sweating, gut function. And it controls temperature regulation. So 98.6 is a fever. All of these are on one circuit. In addition, the next area that uses the most energy for its size will be your muscles. And muscles are like a spring. When they don't have enough energy, they get locked in the shortened position. Now, that's counterintuitive. You think it takes more energy for muscles to contract. But think about it. After you've had a hard day's work, you don't come home and say, honey, my muscles are so loose and limp.
Yes.
You say they're so tight.
Right.
So when the muscles get locked in a shortened position for a couple of days or years, they hurt. They hurt like hell. Now, when you have chronic pain, that doesn't get addressed. It's kind of like the oil light on your dashboard saying something needs attention. It's going off. And as the oil goes lower, it's not being addressed. It gets louder and louder, and you get what's called central sensitization. As the brain tries to get your attention that something needs to be fixed. And then the immune system uses a lot of energy. So when you have an energy crisis, these areas go offline. The key is to figure out what's causing the energy drain and to optimize energy production. We'll talk about that today, an organized approach, because you're going to have a lot of people talking about different pieces of the puzzle.
Right.
It's going to get very confusing for people, especially with brain fog, watching it. So what we're going to do today is organize it all into one piece and then give you simple things you can do today to get started on getting well, because this is a very, very, very treatable illness if you know what to do.
Great. What you mentioned really makes sense. The hypothalamus, you're talking about changes that you cannot see on imaging. You can't see on a brain scan or an MRI, at least not a conventional studies that people would get. And unfortunately, there's no, at least conventional lab marker, fibromyalgia factor, where you get a positive or negative. So it presents a sort of a quagmire for the conventionally trained physician that's used to looking at those objective markers. And we have then all these patients who've been told for a long time nothing's wrong with them, but they feel like they got hit by a train, so something's clearly wrong with them. And that hypothalamic model is very interesting because it is such a master controller of so many of these things. And you mentioned, non-restorative sleep and just what that alone can do if you never go into stage 3 deep restorative sleep. And Moldovsky and others have really picked that apart and talked about alpha wave intrusion and delta wave sleep, but that doesn't really help the average patient, right? That's sort of the academic minutia, but it's just one part of the puzzle. And you talked about these shortened muscles and how it wouldn't make sense that that they would tighten if it's an energy crisis. But as physicians know in physiology, unless you're fueling energy sucking pumps that are pulling calcium and different elements away, that the muscles will actually engage and shorten. So that's really fascinating stuff. And I know that you've put together this system through your years of experience and your writing. Your SHINE protocol has been out there in many different forms. So hopefully you'll discuss that today as a framework of trying to put this all together in a cohesive system.
Absolutely. So if you're looking at an energy crisis in the body, David, the key is restoring energy. So if you use SHINE, which would be sleep, hormonal support, infections, immunity, inflammation, nutritional support, and exercise as able, you'll find that restores energy. Now, you could add detoxification to that, but the SHINE protocol will generally help people to detoxify anyway. So there's a nice organized approach, and people say, well, so we start with sleep, but you can't sleep. And I say, you need to get your 8 hours sleep a night. And they say, Dr. T, you're a nice guy, but you're crazy. I can't sleep. There's no way it's going to happen. And 3 months later, people are getting their 8 hours sleep a night. So I like to use a mix of natural and prescription therapies. I find using the whole toolkit works best. Unfortunately, most physicians are simply not trained in this disease. And if you go to your doctor and you try to teach him about treating fibromyalgia, it's kind of like coming to me and saying I need heart bypass surgery.
Right.
And I say, I don't know how to do that. And you say, well, here's a book from Bypass to Fantastic and a scalpel.
Yeah.
It
Yeah.
doesn't make me a
It's
bad
not
doctor. I
enough.
don't do
Not
that.
enough. Yeah.
And most doctors are simply not trained in fibro. So
No, and even
instead,
today, they get out of medical school and they get virtually no training and understanding of this whole construct. And even the limited, look at what the rheumatology literature is talking about with this hypervigilance, central sensitivity, failure of the descending antinociceptive system. You start talking about that, and the average physician, their eyes glaze over. They have no idea, nothing, and it's
and it's
sad.
okay because
Yeah,
it's not their thing.
right,
But I will tell, if you go to the doctor and the doctor says, I don't know what's wrong with you, so you're crazy, you've got fibromyalgia, there's no such thing.
right,
I think there's a really good approach to that. What you do is you stand up, you walk over to the doctor, you look him in the eye, you give him a big hug, and you tell him, thank you for letting me know up front what an utter idiot you are so I
right,
don't waste my
exactly,
time with you.
right,
Turn around and out the door.
right.
You don't have, life is too short to be wasted on abusive idiots. If the
I
doctor
agree.
says, I don't know what's wrong with you, I'm sorry, then that's a good, honest physician.
Right. I agree.
Because
Couldn't agree with you
that's
more.
okay.
And the patient always has to remember, they have ultimate control. They're the boss, and they can vote
Yes.
with their feet, so to speak. And if they have an obstinate doctor who's very closed-minded and condescending and makes them feel, stupid about exploring other options or bringing up other things, then they do need to find another doctor.
Yes, and let me give a website that's a very good place.
Sure.
There's over 2,000 board certified holistic physicians. It's www.ab, like Bob, IHM, like Mary.org, not .com, .org. So abihm.org. These are holistic doctors. Again, they don't all know what they're doing with it, but they're much more likely to know. So it's a good place to begin for
And at
anybody
least they're open
in
to
North
other
America.
types of approaches as well. They're not so closed-minded, or they wouldn't be part of an organization like that, or the Institute for Functional Medicine, or many of the or A4M and the other ones that are out there.
Okay. So let's go ahead, David, and teach people how to get well. So
Sure.
here's what you can do. So we talked about S for sleep. And there's no one sleep treatment that's going to be enough to get you sleeping through the night. And frankly, the natural remedies by themselves are not going to be enough either. The sleep disorder is so severe that you need a mix of often maybe 5, 6, 7, 8 things. But here's the trick. If you do a high dose enough of one thing to put you out, you're going to be hungover till 2, 3 p.m. the next day. What works much better is to use a very low dose of several different things. This way they're all cleared out of the body by morning. You take it, your blood level goes up. So in the middle of the night, it's not high enough by itself to keep you out, but you're doing 2, 3
Right.
different things. That's additive.
But you
And
don't
then
get a
you're
sleep.
out.
But you don't get a sleep hangover, so to speak, in the morning.
Exactly.
Okay.
And the medications that are best to put you to sleep would be Ambien for putting to sleep. Now, again, I like to keep it 10 milligrams or less because it can be addictive when you start going over 12.5 milligrams. Trazodone, 25 to 50 milligrams. Neurontin, about 100 to 300 milligrams. Xanaflex, 2 to 4 milligrams. If you're having a lot of pain, the tramadol. So these are good prescription things. But again, if they leave you feeling lousy, lower the dose or stop it. And that shoe doesn't fit you. And then from a natural point of view, a half a milligram of melatonin. There's an herbal mix called the Revitalizing Sleep Formula. That's very good for sleep. 5-HTP, 200 milligrams. Again, be a little careful if you're taking other serotonin medications, but for most people, 200 milligrams is quite safe, even if they're on the medications.
Absolutely. Yeah.
And it takes 6 weeks to work. And then the smell of lavender, a little bit of lavender oil just right under on the upper lip. The smell of lavender will help you sleep, or lavender even in capsules. So there's a mix of over 30 treatments that can be helpful. Most standard sleeping pills like Dalmane, Halcyon, Valium actually make the problem worse. Klonopin in low dose does not disrupt the deep sleep like the other ones. So
There's
let
been
me
some
know.
studies, like by Moldovsky, I mentioned before, at the University of Toronto, and others, that low-dose cyclobenzaprines, for instance. What do you feel about those? Because used at a much
2.8
lower
milligrams.
dose, used at a much
2.8
lower,
milligrams.
right, lower dose than you would classically use them for other applications. So it's kind of goes right with what you were saying.
Absolutely. And like I say, there's over 30 different treatments on our treatment protocol. that we supply for people. The cyclobenzaprine, 2.5 to 2.8 milligrams is the main dose. You can just get a 5 milligram pill, break it in half. Again, I'm going to note how expensive a treatment is has absolutely nothing to do with its effectiveness. And the generics generally will work just fine for most people and the best way to go. But you'll find a mix and match. The reason I didn't mention the cyclobenzaprine in the beginning is that a good percent of people have restless leg syndrome.
Right.
With this illness, and that family of medications can aggravate it. But again, it's a very good medication for sleep and for pain.
I notice your melatonin dose is much lower than the classic person would use. They would be using an entry dose maybe of 3 milligrams and even go up to 6 or 9 and maybe use a sustained release melatonin to keep sleep persistence. But you seem to favor a much lower dose.
Well, the 3 milligram dose came from this very important approach. What somebody did is they took that number and they pulled it out of their There's no research I've seen supporting that anything over 0.3 of a milligram is more effective. And all it takes if somebody has a low melatonin, that's a medical term, by the way, and you want to bring the melatonin right up to mid-range, is 0.3 of a milligram. Now, there are times for higher doses. If somebody has acid reflux at nighttime, the 5 milligram dose has been studied, 5 and 6 milligrams, and that can be helpful for the acid reflux.
And they've used very high doses in certain autoimmune diseases, for instance, in cancer therapeutics.
Cancers.
Right. Mm-hmm.
Sure.
Okay.
But for sleep, what I'm saying is that the lower dose does the same thing, and we don't know if melatonin suppresses your own melatonin production. But I tend to be conservative in some ways. I'd rather err on the side of if it's not going to help you, why do it?
Before we leave sleep, I had a question for you. You get some of those patients that come in, with a label of fibromyalgia, and they have the classic anxiety and some panic attack, and their mind's racing, they're hypervigilant, they can't get to sleep. But then you get some of those patients who maybe they can get to sleep, or they have difficulty getting to sleep, but once they do, they'll sleep for 12 hours, but then they get up and they feel like they didn't sleep. They have that classic non-restorative, non-refreshing sleep. Mm-hmm. Is there a difference in the therapeutics in getting them to sleep versus getting them to sleep through the right stages and get restoration?
Absolutely. So if you take a look at those they're tired, exhausted all day, and then 10 p.m. hits and their mind's wide awake like it's daytime,
right,
they tend to have problems with too high of a cortisol at nighttime.
Right.
The adrenal stress hormone is too low during the day, too high at nighttime. And in those cases, I'll give phosphatidylserine and ashwagandha. I use something called Sleep Tonight, which is a nice mix that brings the cortisol level right down so they can go to sleep. Most other people find that between 2 and 4 in the morning, it's like this universal alarm clock goes off and wakes them up. And that is often associated with many things, but also low blood sugar during the night. So if people eat a protein snack, not carbs, it'll make it worse. Right. Protein, like a hard-boiled egg, some cheese, some meat, things like that right before bedtime, just an ounce. That will help keep their blood sugar stable. And they'll know the first night that they do that, it's not going to knock out the problem, but they'll sleep more deeply. There are things, Xyrem used to be in the health food stores and should still be in the health food stores and should be $20 a month, except God bless the government got involved with it, took it out of health food stores, and now it's $20,000.
Right.
Which is insanity. It's a $20 medication is what it should be, and it's natural, and it's very benign when used properly. If it's not mixed in with the toxic juice they put it in with. So anyway,
when that happens, it worked well. Somebody was threatened too much by it, but that's another summit. That's
a whole other subject. So they're trying to do the best they can. Unfortunately, sanity doesn't play a big role in it.
Right.
But there are all these things that can be very helpful, and you need to tailor it. And for those that are watching, if you have a piece of paper and a pen, just write this down. There's a website, www.endfatigue.com. So N like Nancy, D like David, and then fatigue, FATIGUE.com. You'll see there's a free energy analysis program that's on the website. I actually hold a U.S. patent for a computerized physician. I made it for people with fibromyalgia. And what people do is they take a quiz and they answer a bunch of questions. If they have lab tests, you don't need them because the labs and the questions point to the same things anyway. But if you have the pertinent lab test, there'll be a place to enter that. It'll analyze all of that, determine basically what the main problems are in terms of triggering the energy crisis in your body, and then tailor a program to your individual case to optimize energy production. And when we made this, we charged $400 for people to do this. But we told people that if they couldn't afford, we'd let them do it for free. And 80% of people wrote back saying, I have fibromyalgia, I'm crippled, I can't work, I'm broke. So we just made it free for everybody. That's my wife and my gift. Our goal is to make effective treatment available for everyone. So you do the quiz, and instead of trying to scribble quickly all the things you're talking about today, if you have your lab tests, put them in. If not, don't worry about it. You can always put them in later also if you want. And it'll just go through the whole thing and say, here are the things. Look, it sounds like you have restless leg syndrome. Look for sleep apnea. Here's how you optimize sleep. Here's a protocol to do that. Here are things to take to your doctor for the medications more likely to help you. It'll say whether it looks like you have thyroid issues, adrenal issues. So it'll analyze all that. And that just makes it really easy for people.
Great. So let's keep progressing with your SHINE protocol. We've talked about sleep quite a bit. You started talking a little bit about the hormonal support and cortisol and blood sugar and things like that with insulin. But why don't you delve a little deeper into the H component?
So with hormones are our body's control system, and they're regulated by that circuit breaker, the hypothalamus, that goes offline. The blood test missed the large majority of people who need hormonal problems. And why? And this is an analogy I gave Dr. Oz that he likes to run with. He's a friend of mine. He's a very good man, despite Monsanto deciding to get ticked off that he told the truth. But when you look at the lab test, what your doctor doesn't realize in most cases is where that normal range comes from. The normal range, basically you take 100 people, and the 95 in the middle are defined as normal, and 2.5 that are on the high or low end are defined as abnormal. That's it. Says nothing about how.
Classic statistical bell curve with 2 standard deviations on each side. Right. Yeah,
exactly so. 2 standard
deviations. It's a mathematical
deviations.
Model, not based on function and physiology.
Yeah. Basically. Yeah. So if we apply that to shoe sizes, a normal shoe size would be any shoe between size 5 and 13.
Right.
So say you go to the doctor and you say, Doc, I'm tired, achy, weight gain, cold intolerant. You sound like a poster child for low thyroid.
Right.
And the doctor says, see, your test is normal. It's right there on the lowest end of it, but it's normal.
That's even if they did all the tests, because usually they're just doing TSH, which, I could stack literature to the ceiling showing that in and of itself, by itself, is not a good enough referendum on thyroid function. But, even if they do, so all the other thyroid hormone fractions and the total and free forms and all that, a lot of those people are, like you said, within that statistical normal range, but they're on the very bottom. Particularly the T3 levels are way, way on the bottom. And we know, as integrative physicians, we know there's problems there, but their standard physician is saying, oh, you're perfectly fine.
Yep. So what I recommend is give that doctor a size 6 pair of shoes. Tell him, Doc, this shoe size is in the normal range. Please wear this to our next appointment, and then let's talk again about why, if it's in the normal range, it doesn't need to be treated.
Right. Or
better yet, go to abihm.org and find a doctor who you don't have to teach how to do their job. So tired, achy, weight gain, cold intolerant, you got 2 of those. You deserve a trial of thyroid hormone. Most people do best using one that includes both T3 and T4, the active hormone and storage. Most doctors have never prescribed anything besides the inactive T4 in their life. So it's that straightforward. And then you adjust the dose to what feels best while keeping the free T4 within the normal range for safety. An important point, when you are taking T3 hormone, the T3 blood test is meaningless. All it'll tell you is what time of day you drew the blood relative to when you took the dose. So if you take your Armour thyroid in the morning and then you take the blood test an hour later, a T3 will be too high. If you take it before you take the thyroid, it'll be too low. And if you take it 5 hours later, it'll look just right. And the blood test is meaningless. It's a good test to do before you start taking thyroid hormone. And we could do a whole hour on why the test is meaningless if you're taking it by mouth as opposed to what's being made in the cells, which is past the bloodstream.
Right.
So thyroid, adjust it to what feels best. Adrenal, for the adrenal test, you don't have to be in the lowest 1 out of 100 or 5% to be abnormal. You have to be in the lowest 1 out of 100,000 people. It has to be so low that it literally can kill you.
It's
Called
pathological.
Addison's
Yeah,
disease.
right.
And where they put you in a hospital and the whole thing. So most people are on a cortisol of about 18 in the morning. It has to be under 6 to be abnormal. 6.1 is considered no problem at all, even if you're bedridden. 5.9, they do this, and work up looking for the Addison's disease, put the med alert bracelet on you. Now, I've had people where the lab accidentally ran the test twice on the same tube of blood, and your tests routinely come back 4 to 8 points apart on the same tube of blood. So it'll come back 18 on one tube and 12 on the same tube of blood. 6.1, no problem. 5.9,
That makes no sense. You. Right.
None at all. So how do you tell if you need adrenal support? David, I'll give you a very high-tech way. I ask the person, and especially I ask the person who comes in with them when they come to see me, and most people do consults by phone with me, are there periods where it's like you realize you've got 3 minutes to feed them or they will kill you? And both the husband and wife are going like this? That's low adrenal. If you get irritable when hungry, if you have these feed me now or I will kill you moments.
Because they're not getting enough glucocorticoid and they're not getting enough sugar breakdown. And we all know the reasons behind that, but there's a direct connection for those who are listening between the adrenal hormones and the amount of sugar, for instance, in the blood and available for energy.
Yes, and that blood sugar drops. It's the same as suffocating as far as the brain is concerned.
Right.
And you get this irritability. And if anybody gets between you and that Snicker bar, they're dead.
Right.
The problem is if you eat sugar, you'll feel better for a half hour, and then it will crash you even worse.
Right.
So all it takes, you can take half a teaspoon, quarter teaspoon of sugar, maybe a quarter packet of sugar, and put it under your tongue, and that will break the attack within a minute, and then eat protein.
Right.
So for the adrenal, that means you need to increase your salt and water intake a lot. And I know the listeners are going to say, but I'm peeing 4 times as much as my husband. I'm saying that you're drinking 4 times as much. But yes, but you're peeing 5 times as much.
Right.
The description, drink like a fish and pee like a racehorse.
Right.
In this disease, because the hormone that holds on to water is also low. So adrenal support, salt, water, avoid sugar. You can take licorice, not the candy, but real licorice. Ashwagandha is helpful.
Right.
Vitamin B5 is helpful. Adrenal glandulars. I like a mix called Adrenal Stress End, where you take 1 pill in the morning and it has all these things and it just smooths it out. I will use very, very, very low doses of the bioidentical cortisol in the morning. I consider it quite safe, up to 15 to 20 milligrams a day. Our research showed that there was no adrenal suppression using these low doses. But when you go to 25 milligrams or higher a day, you will see adrenal suppression begin.
So the classic doses for, uses in autoimmune disease and inflammatory problems, they're much higher than you're talking about for treating the adrenals.
Yes. Yeah. Prednisone 5 milligrams, which is the lowest most doctors ever give, is like 25 milligrams of Cortef.
Right.
And for autoimmune disease, you'll often see doses that are like the equivalent of 20 to 30 pills
40.
of Cortef a day, where we're giving just 1 or 2.
Right. Good. Okay. Anything else on hormones, or do you want to move on to the next?
Well, let's do a quick thing for testosterone.
Okay.
70% of men are in the lowest 30th percentile, so you want to give the bioidentical. Women, research by Professor Hilary White showed that low doses of testosterone help fibromyalgia pain. But how do you tell if you need estrogen and progesterone? It's very simple. If your fibromyalgia symptoms, I'm not talking about PMS symptoms, that's low progesterone, but if your symptoms of fatigue, insomnia, brain fog, pain are worse around your menses, that suggests that low estrogen and progesterone is a contributing factor to the fibromyalgia symptoms, and I will use some bioidentical hormones to see if they're helpful as well. So you'll find it's very simple. Tired, achy, weight gain, cold intolerant, thyroid. Irritable when hungry, adrenal support. Symptoms worse around your menses, erectile dysfunction, decreased libido, hormone replacement therapy, estrogen, progesterone, testosterone. It's not rocket science.
Right. Or all of the above, right?
Oh, absolutely. Yeah. And with the thyroid, there are literally dozens of different approaches to treatment that you need to see which one for that individual.
Right.
That's when it gets more rocket science.
Okay, well, let's talk about infections and immunity as part of the SHINE protocol, because I have a particular interest in the infections, and particularly a lot of the stealth infections, stealth viruses and things, and it's related to a lot more chronic disease than what we're talking about today, including the genesis of autoimmune inflammatory disorders and molecular mimicry and all of that. But just staying on our topic today, how do infections, either overt or stealth ones, relate to this problem?
Well, the immune system is down in general in this disease. So I don't think there's one infection which is the cause.
Right.
And there's dozens that have been implicated. But I think when the immune system is down, your body will pick up a host of hitchhiker infections. It's like a pack of dogs. And no one of them is that big. I mean, you'll find things like Lyme disease and other ones that can be important. But overall, the problem is more, I think, with the immunity than it is with the specific infection
right,
themselves.
So they're just opportunistic sort of flare-ups of even things that are sort of ubiquitous, EBV and CMV, all these viruses that sort of we're all exposed to, but we kind of keep in check, but these patients just simply can't do that.
Exactly. As you say, opportunistic, which means an infection that a normal immune system will kick out right away.
Right.
So what are the most important infections to treat, and how do you tell? Because the testing is not reliable for infections either. Most of our medical testing is geared to pick up acute, fulminant, overwhelming infections, whether it's a sore throat or it's a pneumonia or things like that. But it's not geared to pick up chronic low-grade infections, and will not tell the difference between an old infection that's gone and one that's reactivated. So because of that, the way that I'll look at it is Candida, I think, is the most important infection. If you look at it basically in terms of size and scale, if a viral infection, if a virus was the size of a pinhead, and a bacteria might be the size of a living room, and the Candida bug can be bigger than a skyscraper. I mean, these are massive organisms to your immune system, and they also cause problems in the gut with digestion of partially absorbed food, incompletely absorbed food, which then your immune system has to go and digest all that food, treating it like outside invaders, just where I get the food allergies. So the Candida, I will treat in virtually everybody. How do you tell if you have it? If you have nasal congestion, postnasal drip, if you have gas, bloating, diarrhea, constipation, all of these are signs of Candida. When you treat the Candida, they usually go away. The sinusitis, I will add a sinus spray. I will use diflucan for 6 weeks, combined with either nystatin, berberine, or any of a number of antifungals. You want to use the two together to prevent resistance of drugs, of the organisms. I will use sinusitis nose sprays. There's different ones made by ITC Pharmacy, Hunter Pharmacy. There's a number of different ones that have antibacterial, antifungal properties. The combination works very well. Most people's sinusitis will go away with that mix. If the gut symptoms persist, and especially if you have a foul odor when you pass gas, that sulfur smell that used to be called silent but deadlies back in grade school.
Yeah. I think they still do. I think they still call them that. I have a 9-year-old and 8-year-old boy. And I think I've heard that.
There you go, exactly. And that's a sign of bacterial overgrowth, often called small intestinal bacterial overgrowth. And in that case, if it persists after the antifungal, I'll go with rifaximin for 10 days, which is a specialized antibiotic for that, or neomycin if the insurance doesn't cover it. In terms of bacterial infections, if you have allergies to multiple unrelated antibiotics and not to everything else, that says it's not an allergy. If you're allergic to penicillin, Cipro, tetracycline, and nothing else, these are chemically unrelated. So it wasn't an allergy. It was, in most cases, it's a die-off reaction where you're killing something, and killing the thing initially flared the symptoms. If you have chronic low-grade fevers, if you have lung congestion, if you have a history of having had your fibro feel better when you're on an antibiotic, any of these things I will consider a treatment with antibiotics. If the HHV6 or CMV viral titers are over 4 or over 1 to 320, I will consider also going with an antiviral, the Valcyte, for 6 months. Otherwise, now, are you using the Valtrex and Celebrex combination or the Fanver Celebrex yet? David, what are you seeing?
I have not been using that, no.
Okay. But we're going with those as well. And also, especially if you have a history where your illness began like I had it. I mean, people ask me how I got involved in this illness. And I said, well, been there, done that. When I was in medical school, And med school was the easiest part of my life compared to the rest of the chaos going on. And then I got what I call the drop dead flu. And it left me, basically non-functional. And I had to drop out of medical school. And since I was paying my own way, that meant no work study, no scholarship, no loans. I was homeless, sleeping in parks.
Wow.
And it's funny. It's as if the universe put a homeless medical school sign on my park bench. And physicians came by, chiropractors came by, homeopaths, naturopaths. I almost became a naturopath because of that. And a host of other energy workers, acupuncturists, and all of them taught me bits and pieces. And if they fed me, I ate.
Right.
The days I didn't, and
well, you were motivated to find solutions to this puzzle, obviously.
Oh, I thought my life was over. I mean, my whole life was geared to being a physician and healer. And when I had to drop out of med school, I didn't know there was any going back.
Right.
I thought that was it. But people would come and teach me these things. And I don't know if motivated was the word. I was interested.
Right.
Because I'm fascinated by all of this. And I was able to put together, sew together the different bits and pieces from all these different folks and get myself well. And then went back to medical school, did great, and have spent the last 35, 40 years or so focusing on effective treatment for everybody for this illness. So for me, having that drop dead flu thing, I would consider people who started with that going with an antiviral as well.
Right, and it's so common that we see patients that, their symptoms seem to have all, started, or the whole thing started going wrong after a significant viral or flu-like illness, particularly in the chronic fatigue. They used to say chronic fatigue immune deficiency syndrome, that whole variant, and look at all the T-cell ratios and all of that, and not necessarily lumping all chronic fatigue syndrome and fibromyalgia necessarily, but it's not uncommon to get these histories no matter what the diagnosis they come in with.
Mm-hmm. And the thing is, I don't use the testing as a key way to follow up what's working. What I do is I ask the person, do you feel better on this?
Right.
They give it 4 months, and if they're feeling better, it's working. If not, it's not.
Right.
So I think a lot of the tests, instead of recognizing that we don't have reliable testing yet, and you need to just treat the person and not the blood tests, we are looking at some test.
Right.
No, how's it working?
Right. A lot of conventionally trained physicians are just scared to operate on that paradigm anymore, which used to be the norm, right? Because they're worried that they're going to be outside some standard of care, and they're going to be brought before the board, and they shouldn't be using this because there's no objective test. So it's a disconnect with the conventional system meant to treat, like you said, acute disease, and they're very good at that, but they're just not very good at all this chronic stuff, or else we wouldn't be having this summit right now. Right?
Exactly. I feel like this, small town doc who's teaching, the professors. When I said, "Wow, why should I be the one doing that? They should be doing it, not me."
Right.
But until they are, here we are.
Yep. How about I want to make sure in the time we have, we get through the whole SHINE protocol. So the N is nutritional support. So talk a little bit about that.
Straightforward. Most people do well with a high protein, low carb, low sugar diet, but eat the diet that leaves you feeling the best. High salt. If you salt restrict with this disease, you will crash and burn. I like a good quality sea salt, but really any salt, your body needs it.
But doctor, I have hypertension. My doctor told me to stay away from salt.
Yes, and you know what the studies show with high blood pressure? If you salt restrict to a level that's virtually impossible to maintain, your blood pressure goes down 0.8 of a millimeter.
Right.
And that's it. So the research shows that the main benefit of restricting salt is that, to the government guidelines, is that you die younger. And our Social Security system thanks you.
Yes,
increase salt. And the chocolate, by the way, healthy food. I've been saying for 30 years chocolate's a health food in moderation. So in terms of nutritional support, which vitamin and mineral do you need? All of them, and the amino acids and the rest. So instead of taking 50 pills a day, there's one powder. It's called the Energy Revitalization System Vitamin Powder. I recommend that for everybody because this way it just simplifies their program. It's one drink, and I add a scoop of ribose to that. Our research showed that ribose increased energy an average of 60% after 3 weeks of use in fibromyalgia. Now the ribose gets a bit pricey. It was about $50 for a container. So it's now available, and we put it on Amazon. You can get it at nfatigue.com. It's called Shine Ribose, and it's $20 for the 280 grams. So it's about half the cost. So it's 70% lower than the other. So it's now cheap, easy, and it's the form used in the research. So, but the ribose is 5 grams. I give it 3 times a day for the first 3 weeks, and then once or twice a day. If people just do the 1 scoop in the morning along, and then add the vitamin powder and add water in 30 seconds. It's not expensive. It's the best 30 seconds you'll spend all day for energy, pain, and how you feel overall. Coenzyme Q10, 200 milligrams a day, or you can use your ubiquinol forms. Acetylcarnitine for 3 months, and then I stop it. But I think for the first 3 months, it's important to use it. There are a host of other things that can be helpful, but those are the key things.
And nutrition. Then, how about the final letter is E for exercise, and that's always a big dilemma for many of these patients because they've often tried to exercise, and the minute they feel worse. They have worse energy. They feel like they got hit by a truck, particularly if they go into exertional, like anaerobic, type of exercise. So how do you? I noticed that you put a modifier on your thing. Right.
Able.
Right.
Because as you know, if you do too much, you're going to be wiped out. Most people, if they do more exercise than they normally do, their body conditions. They send a message that say make more energy in these muscles, and they bulk up and they condition. But because of the energy crisis, you can only make a certain amount of energy. So instead of conditioning, you crash and burn. And then you're afraid to do anything, and then you decondition, which part of this illness is the hypothalamus, which controls autonomic function, which is blood pressure pulse. So you see the POTS, NMH, these blood pressure issues being too low that are a major problem, and the deconditioning makes that horrible. So you start with a walking program. You walk as much as you comfortably can, whether it's 50 steps or 50 minutes. You know, your body knows. And then after 10 to 12 weeks on the SHINE protocol, energy production skyrockets. And then you'll find you can increase your walking by 50 steps every 1 to 3 days. Get a little $15 pedometer. And you'll find that as long as you feel good tired after, better the next day, it's good. Wiped out, you did too much. David, let's take a moment to talk about pain also.
Okay.
Pain relief it's never acceptable to leave somebody in chronic pain, and you almost never see people who you can't get adequate pain relief for. What medications? Their doctor's going to hear about Lyrica, Savella, Cymbalta, because they're spending $210 million a year advertising, which God bless them. At least their doctor's hearing about fibromyalgia, and they're turning
what people don't know is they're repurposing or repackaging of drugs for former uses that were approved for other things first. So
that's fine by me.
Yeah, right.
But they're expensive, and they're not without side effects.
Right.
What medications I prefer? Tramadol, Neurontin. These are 2 very good medications that work well for people. Low-dose naltrexone.
Right.
But you want to give it to 6 to 12 weeks. 4.5 milligrams is the maximum dose. And then the Lyrica, Cymbalta, Savella, Xanaflex can be very helpful for pain. They're having new research with Namenda, which I think doesn't work worth a damn, in my humble opinion, for Alzheimer's, which is what it's marketed for, but can help if you have the allodynia, where normal touch hurts kind of a thing, or if you have severe pain not hit by other things. There's so many different things you can do. And for those who need narcotics, which most people don't, but realize that if you do, it's going to make you be vitamin deficient, and it's going to cause testosterone deficiency. So those also need to be addressed, because otherwise both of those will then aggravate the pain. Natural pain relief, Curamin is a mix that's outstanding. Give it 6 weeks to work. You can take all of these together if you needed to. And pain can be very helpful, and then topical comfrey. If you have localized areas of severe pain, say you have the wrist or elbow pain or low back pain, the compounding pharmacies can make a compounding cream that has 5, 6, 7 of these medications in it. And after 2 weeks of rubbing it in 3 times a day, you get the same tissue level as if you're taking all 7 medicines by mouth, but the blood level is 0, so there's no side effects. There are so many ways to get pain relief. And what our study showed is that we talked about pain being like the oil light on your body's dashboard. You put oil in the car, the oil light goes out. You give your body shine, and the pain went down by an average of 50% in our study. And this was a randomized, double-blind, placebo-controlled study where everything but the exercise was blinded. And the pain went down. Most people no longer qualified as having fibromyalgia by the end of the study at 99 days. So these are very, very treatable. And again, at the website, theendfatigue.com, you can see the studies that are published. And the energy analysis program is a simple quiz that will tailor a treatment protocol to your individual case to help you optimize energy and to tell your physician what they need to do. Because it's just all going to be laid out for them. Here are the things in your case that are most likely to help. And I do see people in consultations from all over the world, including by doing phone consultations.
Great.
So that's something as well.
In the short time we have left, I wanted to ask your opinion on something, because it's interesting that most of the large studies on fibromyalgia pain, the opioids, have limited benefit, and it's kind of a bit mysterious. But things like low-dose naltrexone, which you mentioned, seems to be effective. And there's theories out there now that it's not really the normal mechanism of action that we associate with naltrexone, with the opioid sort of manipulation, that it's more the pleomorphic, anti-inflammatory effects in the, and you'd say, well, most of the studies show that fibromyalgia is not overtly systemically inflammatory. It's not an itis, right? You don't have all these inflammatory markers high, but there's new information that there's microinflammation in the brain, in the microglia of the brain. Do you think that the low-dose naltrexone is actually acting in that sort of brain microinflammation more than modulate? Yeah, okay.
When you see the chronic pain is more toxic than the narcotics because it triggers changes in the microglia. It basically triggers chronic pain, or what I call brain pain, or central sensitization. You'll see the same thing with reflex sympathetic dystrophy, or experts are also seeing that the low-dose naltrexone can be very helpful, as can a number of other treatments. And the theory is that it decreases the microglial proliferation that occurs that causes the chronic inflammation. So the bottom line with low-dose naltrexone is we don't know.
Right.
Except we know it works.
Right.
Why
it's
it works.
Interesting that vitamin D is a pain modulator as well, it turns out, and it has similar pleomorphic effects, and it might be acting on that axis as well. So it'd be interesting to see what the data shows going forward. But like you said, until we have it, we have observational data that we see every day in our practices, and especially with these things that really don't have a downside or a toxic effect, there's really no reason to wait until there's some gold standard trial out there to suggest that they are the right thing to do.
And especially being cheap, don't hold your breath for that trial to happen.
Right, exactly. Yeah, we all know the economic model and disincentive to actually even seriously study these things. The final thing is the mind-body connection. I mean, one of the things I see is many of these patients have adverse childhood events. They have a lot of trauma. They have really bad upbringings. They've had some significant stressors, particularly when their nervous system was young and very neuroplastic, and they've kind of got locked into this hypervigilance, when's the next shoe going to drop kind of stress mentality. So there's a lot of good studies out there on cognitive behavioral therapies of many different types. Do you utilize that, and do you feel like that's an essential component?
Well, David, here's the thing. The cognitive behavioral therapy is simply a therapy that teaches you how to cope with any chronic illness. So if you have multiple sclerosis, which used to be called hysterical paralysis, or cancer, or any of a number of things, learning coping skills is good. The problem is that there's a small group of people doing CBT who think that they should try to convince you that fibromyalgia is not real and that you're crazy, and convince your family members that you're crazy, and convince the doctors that you shouldn't get any treatment except their psychiatric treatment. Now, if they did this for people with, cancer that were crippled, or paraplegics, or MS, people would come and wring their necks and throw them off a building, which, when people now threaten to do that to the people who are, it's funny, you have some that are basically attacking cripples using CBT by saying they shouldn't get any of the benefits. And then we say, well, what do you mean you said? And then oh, no, we didn't say that, but they do. And then they go and they testify before their, the governmental agencies that they know, but they shouldn't. It's almost as if, I don't want to say it, but anyway. So if you're using CBT to learn coping skills while also treating the rest of the physical components that are going on, just like any other disease, just like cancer, then it can be very helpful. But if they're saying, well, you should believe that you're crazy and this is not real, I wouldn't even bother giving that person a hug. I just
since stress,
give them what in Hawaii we call stink eye.
I heard about that.
There's visual. You can give them finger and other gestures to express your displeasure and leave. They're idiots.
But I mean, we know that there's an aberrant stress response in many of these patients, and it's, it's part of this whole model of limbic system dysfunction and hypothalamic. So it makes some sense that changing the way they perceive or deal with or process stress may be helpful to the even inner mechanisms of the disorder. Would you?
Yeah, absolutely. Right. And you know me, David, I'm a high-tech kind of guy, so let me give you a high-tech approach to that issue. First of all, having had this illness myself, the psychodynamic I tend to see in all, multiple sclerosis tends to be repressed rage, heart attacks associated with hostility that's, repressed, chronic fatigue syndrome, low self-esteem as a child, overachieving, trying to get approval from somebody who just wasn't going to give it, trying to be all things to all people and taking care of everybody except one person.
Yourself.
Right. And then there's also the inability to say no because you want to avoid conflict. So what will happen, remember we talked about this being an energy crisis, and then people will come by, and when you have the chairwoman of the committee of 1,000 ways to waste everybody's time comes walking down the street, everybody heads for the alleyways except for you with the chronic fatigue and fibromyalgia. You're like a deer in the headlights.
Right.
And they walk up and they say, we need you to do this. If it's like an energy vampire. You have to do. Who else will do it? They put their energy hooks in you, and then if you don't do it, who would do it?
Right.
And then we're so wonderful, and then they compliment you, and meanwhile they're sucking you dry. And the way that you know that you got hit by an energy vampire is you feel worse when you've talked to them.
Right.
So here's a simple trick. If something feels bad, no matter who says it, if I say something that makes it feel bad, anybody says something that makes it feel bad, there's a simple 2-word solution. No.
Right.
If something feels bad, you can go graciously, no, I'm sorry. My doctor said that if I take on anything else, he'll wring my neck. And you can. I'm telling you that. I'm the doctor. So you can say it honestly to a person.
Right.
And if they keep pushing, then it's like, my doctor said if I do what you just said, it could kill me. And then you go into a little huff, and then they'll go, oh, they'll back off.
Right.
So what you tell them is, I really don't think I can do it. And here's the trick. Let me think about it, and I will get back to you if I change my mind.
Right.
That's enough for you, like a shoehorn, to slip out of the situation. And it's left in the thing where if you don't get back to them, it's a done deal.
Right.
And you're going to get home and feel like you dodged a bullet.
Right.
So if it feels bad, say no. If it feels good, do it. It's that simple.
Well, that's great advice, and this interview felt good, so hopefully it will to everybody. And I just wanted to, again, let everyone know that they can learn more about you and your work at endfatigue.com. Is that the best place to do so? Great.
Yes, ENDFATIGUE. Also, for those with iPhones and Androids, there's a free app called Cures, C-U-R-E-S, capital A-C. It'll have everything from acne to zoster and how to get well from it.
Great. Thank you very much, Dr. Teitelbaum, for all your work and your careers. Additions to what we know about fibromyalgia and fatigue and all the people you've helped. So I appreciate it very much, and taking the time out of your busy schedule to be with us on the Fibro-Fix Summit. And for those of you watching, if you want to take this information home and own it and share it with others who may benefit, either click on the side or below on the banner where you can access that. And we're going to be interviewing many other experts on the summit, and hopefully you'll get some information that will help you along the way. Thank you very much.